Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to CVS Healthcare, Health Lyrics, and Worldwide Technology, who are our Newsday show sponsors, for investing in our mission to develop the next generation of health IT leaders. We set a goal for our show, and one of those goals for this year is to grow our YouTube followers. We have about 600 plus followers today on our YouTube channel. Why, you might ask? Because not only do we produce this show in video format, but we also produce 4 short video clips from each show that we do. If you subscribe, you'll be notified when they go live. We produce those clips just for you, the busy health IT professional. So go ahead and check that out. We also launched Today in Health IT, a weekday daily show that is on todayinhealthit.com. We look at one story each day and try to keep it to about 10 minutes or less, so it's really digestible. This is a great way for you to stay current. It's a great way for your team to stay current. In fact, if I were a CIO today, I would have all my staff listening to Today in Health IT so we could discuss it. Agree with the content, disagree with the content. It is still a great way to get the conversation started, so check that out as well. Now, on to today's show. Welcome to This Week in Health IT. It's Newsday. Walmart, CVS, Microsoft, and Watson Health, and whatever my co-host and I decide to talk about, which could be pretty interesting. We'll see. My co-host for today is Ann Weiler, former CEO of a healthcare startup. Good afternoon, Ann.
Yeah, I'm in Seattle. It is afternoon.
Great. So I just had, are you fully recovered from the healthcare CEO thing?
No, well, yes and no. It's a hobby now. So I think that's not recovered, because that might not be digital health being your hobby. Maybe says you need some better hobbies.
I don't know. It seems to be, well, it's my job and my hobby now. So
yeah, exactly.
I spoke to Todd Johnson, and Todd Johnson was a CEO, sold right around the time you did. And he's now working with Avia. And we started talking about the stages of health tech CEO recovery, I guess it is. So let me see if I get some of them. There's sort of a joy, right? You sold it, and there's sort of a relief because there's just this constant pressure of running something. But then it quickly turns to sort of oh God, like almost a panic, like, I have to take care of all the things in my life that I've neglected for the last number of years. And then you say, all right, I'm going to give myself a rest, and you start to rest. And then boredom kicks in pretty quickly because you've been running at such a quick pace. And then extreme boredom kicks in. And then you're like, all right, what am I going to do next? Is that
a global pandemic?
Or a global pandemic, which does what? Get you back in the game quicker?
Yeah. Yes, definitely. I mean, I was doing some consulting. Again, in the hobby, I'm really interested in tools for seniors and aging in place. So I was doing some consulting there, and I did some consulting with Techstars. They had a longevity accelerator. But when COVID hit, then suddenly, at least in Washington state, we were immediately told, stay home. And not just stay home, but only go to places you can walk to. So, I was just at the phase of like, okay, I've, little consulting, some time off. Maybe it's time to do a little bit of traveling as I slowly contemplate my next thing. And then it's like, well, actually, why don't you just stay home? And so I'm like, well, if I'm staying home, maybe I should be working. So I went and got myself a job at Amazon, which is completely unrelated to healthcare, which is why I shouldn't say completely unrelated. We have customers that are in AWS that are in healthcare, but it's not my specialization right now. It's my hobby.
That's interesting. Have you found, so you're in Seattle, I'm down here in Florida. I live in a fairly desirable area. Have you found that the real estate prices are going up?
Yes. Yeah.
I mean, I think people are leaving the cities in droves and finding places like your place right there with a nice view of trees.
Well, I am in the city. I'm in Seattle proper, but Seattle proper is a strange place because we have all these lakes and freeways. And so what ends up happening is these concentrated neighborhoods. And so the neighborhood feels very residential, but I am actually in Seattle. I'm just not downtown. But yes, my neighborhood is, houses are getting snapped up. There's not a lot of inventory. Yeah,
Yeah,
it's very.
our subdivision. I think has like 600 homes in it or something to that effect. And I was asking somebody the other day, what's the inventory look like? They said, well, there's only 7 homes available. And I said, well, is that normal? They said, no, usually it's like, this is the prime season to be selling down here. Said usually the inventory is like 30 to 40.
Yeah.
It's just, and gosh, you have to feel bad if you're one of those 7 homes, I guess. Anyway.
Hey, I have a question for you. I saw your blog post on going to Disney World and the COVID precautions that they took and everything. But I was wondering, like, given the timing of your trip, were you having HIMSS withdrawal?
Oh, that's an interesting question. No, no, I explained this on last week's show with Sushade. My wife was the primary caregiver for her father, and around Christmas time, I started saying, all right, we need to get you away. It's been 3 years of caring for him. And I wanted to get her away. And we had gone on our honeymoon to Disney World. And
Nice.
I thought, okay, this is good because we could go there. It's only a couple hour drive from where we're at. So if anything happens with her father, and we arranged for someone to come down and stay with her father. But then her father passed away. And so I looked at her, I said, you still want to go? She's like, I absolutely want to go. And the couple that was flying in to look after her father said, can we still come down? Because because there's 2 feet of snow on the ground here and you really want to come down. And I was like, yeah, you can still come down. So we went up and then came back and hung out with him. And it was, as I've told, it's actually one of the most listened to podcasts on the Today in Health IT show is my trip to Disney World. Because I think people want to.
Everyone's having HIMSS withdrawal.
Well,
they're missing their annual trip to Disney World.
I think everybody wants to know. It's like, what does it look like? What does Disney World look like post COVID? And I don't think we know yet. I think it will continue to evolve over the next 6 to 9 months. So we'll see. See what happens. Hey, you want to talk a little health IT stories and technology? All right, where do you want to start? There's a lot of interesting stuff. I like to save all the edgy digital stuff for our conversations.
Go ahead. Tell me what you've been reading.
Well, yeah, let's do, I don't know, you want to do home and home monitors, you want to do Walmart strategy, and
I've been watching both of those. So
all right, so the Walmart strategy, I personally, so I sent you the story from Business Insider. I personally am not a huge fan of the story. They found 8 current and former employees. They have a new CEO, and they were sort of asking them, how's it going over there? And they got, like 3 people said, oh my gosh, we're in complete disarray. And, 3 other people said, hey, it's full steam ahead. Clinics are going well, that kind of stuff. And the title of the article is Walmart pulls back from their clinic strategy.
Yeah.
So, but it's slowing down pretty significantly according to the article. And I don't think you can make those numbers up. There's there was a belief that they were going to get a couple hundred, or at least 100 or so by the end of 2021. And it looks like they're going to get, I don't know, 30, 40 some odd clinics stood up. And so, that's kind of a hard number to look at and say, are they making progress? On the flip side, there was a global pandemic. Maybe that slowed it down a little bit. I don't know. But what are you hearing? What are you reading on this story?
I was wondering, yes, there's pandemic, there's telemedicine, perhaps we don't need quite as big a footprint. I also wonder if, at what point do we have a saturation of handy clinics? I mean, not sure what's going on near every Walmart, but here in the Northwest, we have Zoom Care, which is trying to be that everywhere clinic. And then, my closest place, if I wanted to go, is an urgent care that is owned by Multicare. It's a collaboration. Then you've got the concierge care. So it's the One Medicals, and everybody, because healthcare has been such an in-person thing, even somebody trying to build a new virtual business is trying to have a footprint. And so I just wonder, were they looking at it and, certainly the initial, hey, there's a clinic in Walmart, like that makes perfect sense, and convenience and all of these things. But maybe there's a question about how many clinics you actually need. And did telemedicine and the pandemic actually say, oh, actually, we don't need such a big footprint?
Well, that's an interesting point, that you look at how this is sort of rolled out and transpired. Maybe they are rethinking their strategy and not moving as fast. I mean, that's one aspect. The second aspect I always remind people is, Walmart is amongst those companies, maybe not in the edgy tech space, but they're still one of those companies that does that experiment, learn, and then scale at a massive level. So it's not something you turn your back on, because if you turn your back on it too long, they might come back with something else. You might be right on the footprint, though. The footprint they were building, so they were going from the in-store clinics to a fairly sizable chunk of their parking lot that they were standing up. And we've seen these facilities go up. It's comprehensive, so you can get mental health, primary care, you can get x-rays, images, labs, you name it. It was a great one-stop shop kind of model, but it is a lot of real estate if we have a fundamental shift in how primary care is delivered.
Yeah.
So we'll have to keep an eye on this one. It still makes a lot of sense to me. Here's a related story. Kaufman Hall today, I've read a couple of them. I think they did their study probably over the last couple of months, and I've said, the health systems are taking a significant hit, between 50 and 100 billion dollars. And I think, and they attribute that primarily to COVID, which is probably true. But I think what's going to happen coming out of this is they're going to say, hey, the COVID numbers never came back. And I think one of the reasons the COVID numbers won't come back to their pre-COVID levels is because new entrants figured out a way to sort of sneak in here and squeeze in here, especially across telehealth and urgent care clinics like you described.
Yeah, and if you think about some of the beginning of the pandemic, I once sat on hold, on hold for a telemedicine visit with the University of Washington for like 5 hours. Soon as it just, like, the system was just overwhelmed. This was when there was absolutely nothing in person, and you immediately had to go to virtual. And I thought I had COVID, and I may have had COVID, who knows? But the system kept crashing, kept booting me out, kept, I think, prioritizing other people's issues ahead of mine. And, there becomes a point where your loyalty to your system, whether, they have all my records and my primary care doctors there, is not, I'm going to weigh the options of, like, do I want care or consistency?
Yeah, I had a weird, and I'm trying to figure out if I like this or not. I had a weird experience this week. I had to do an overnight visit to a hospital for observation with something that was going on. So I did that. It happened to happen at a time where I was between closing my company in California and opening my company in Florida. So I was without insurance. And so you get the $27,000 bill.
Yes.
And
you never want to be in observation. You want to get admitted. That's what Elisabeth Rosenthal says in her book.
Really?
Yeah.
See,
it's basically, she's got this whole thing of, like, how to avoid bills, and, like, the observation, they can charge you a lot more money. And one of the things is, like, always ask. And if you're under observation, either say, well, either I'm well enough to go home, or I'm sick enough to admit me.
Yeah, that's interesting. And I did a ton of tests and that kind of stuff. $27,000 something. Oh, great. So I get the phone call. Hey, we sent this to your insurance. They turned it down. I'm like, yeah, that's because I don't have insurance right now. They said, oh, okay. Well, let's change this to cash pay. I said, okay. So they changed it to cash pay. They said, all right. So the new amount is, right off the bat, they give me a 65% discount.
Wow.
Okay. So I'm like, 65%. Wow, this is great. And I said, hey, is there any additional discount if I pay it all at one fell swoop? And she said, yeah, let me look. Yeah, it's another 20% discount. 85% discount off the $27,000 observation bill. And
Wow.
so my first thought is, lucky me. My second thought is, does that eat away at the credibility and the trust that I have with my health system to know that they're able to charge 15% of what they originally were going to charge and still make money?
Yeah. Yeah.
It's I don't know. It's a weird dynamic. I clearly I like it. I'm really happy. I hope they don't listen to this episode and think I'm ungrateful, because I'm really grateful. But
Well, of course you're grateful for the care. It's just that you want the care and the cost to align. I would say, just for the listeners out there, assuming there are people listening to us talk here, not just the two of us, but the book I was talking about was An American Sickness by Elisabeth Rosenthal, who's the editor of Kaiser Health News. And if you haven't read it, if you're in healthcare and you haven't read it, it's fantastic. She breaks out the, how we got to here. And I think for me, what was most shocking was that everyone is complicit. Like everyone, they talk about everyone taking their cut, but there really is a lot of that. But she also at the end says, I don't have a global solution, but I have a local solution. And there's this whole checklist of, like, if you're going to the hospital, all the questions you need to ask. And also that business about, out of network, like you need to give them a piece of paper before your surgery saying, I'm not condoning any out of network physicians, because that's where some of the costs come in. Anyway, yeah. Not new news, but a great book.
Interesting. Well, I will have to pick that up. It's your hobby. So these are the kind of books you read, like, while sitting out by the lake, I guess.
That's right. Well, and you know what? I had the great fortune of, I was speaking at Mayo Clinic Transform conference one year, and it was pretty incredible. On the way to the conference, because I was a speaker, they helped me get there and everything. I was with Dr. Bonku from Jefferson and got to talk to him about the innovation they were doing. And on the way back to the airport, I was with Elisabeth and got to talk to her about her book. So if I had been one of your guests at that point, I should have been actually interviewing these folks.
You would have. And with that kind of experience, at some point, I have a feeling you're going to have the itch to get back to healthcare. All right, you tee up the next story. You pick one of yours and just throw it out there.
Yeah, so I've got two stories, and they're both, the reason I picked them both is because I have some personal experience with both of the companies. So one's IBM and one's Microsoft. So there was an article about, and a number, the first one was in the Wall Street Journal, but in a number of places, about IBM trying to sell off their Watson health business. And I just thought that was so interesting because, they came out of the gate. They were so early in trying to apply AI to health data to find all of the insights that we know are in that health data, but it just went terribly wrong. And I think, I don't know if you remember this, but there was a session at HIMSS a couple of years ago that was Mayo Clinic, MD Anderson, and Watson, and they were talking about, what they were trying to do and how hard it was. And that very day, MD Anderson actually announced that they were no longer working with Watson. So that wrangling the data was really hard. And in fact, they were trying to do a cancer moonshot, but they ended up doing things like patient scheduling, which is another problem. But at the same time, I think Mayo Clinic is doing some work now in actually themselves and working with Google, because they've chosen Google as their cloud provider, in actually getting those insights from the data. So big challenge. But my personal story here is that when we were a tiny little startup, we were actually an IBM Watson partner. And we were like, I'm serious, it was before their partner program was even in place. And we were like, wow, this is amazing, And we couldn't, once we figured it out, this also makes perfect sense, is that IBM doesn't actually have any data. So they have to partner with anyone possible, that whether that's a health system or another vendor, to get the data. And they are, I want to say, like, I think they're actually they're alone in this in the industry. Like every other technology company has some place that they have some data that they can analyze and then compare things to. Like Google's got all the search data and, was doing the work with Flu Finder for a while. But I think the biggest challenge with IBM was that they had nothing to start with. And if you don't have data, you can't train your algorithms. And so no matter how smart your machine learning is, if it's not being trained on anything, it's not going to get any smarter. So it's an interest. It's great moonshot, but I think fell down in the execution and the key execution of like, where are we going to get data from?
Yeah, it's well, and they went out and bought it, right? So they went out and they bought Explorus.
Yeah.
And Explorus had data from a fair number. I mean, Explorus was pretty big at the time they bought them, a fair number of health systems. And we were one of those health systems in Southern California. We were also an investor in Explorus. So we were happy to see them, with an exit. It's not in the unicorn exit status, but it was a pretty good exit at the time. Yeah, you were talking about this. Let's see, 2013, they started with the MD Anderson pilot to mine for insights from health systems' vast troves of research and patient data and develop new NLP-powered decision support tools. By 2018, the two organizations had fallen out, with MD Anderson pulling the plug on the project after spending more than $60 million following multiple examples of unsafe and incorrect treatment recommendations. Yeah, and I remember when that happened, because they came in, they had the big booth at HIMSS. They were talking about all the things they were going to do. I even went to a session, I don't remember if this was at HIMSS or Chime, where the IBM people were talking about what they could do for us. And essentially what they mapped out was a normalization of a sort of a data governance / normalization of our data to make it ready for AI. And I thought, that's interesting. And by the way, the project they mapped out for me was probably a $60 million project just to clean up the data. And I was like, well, that's amazing. They found, and by the way, I still think AI and machine learning on the clinical side is still highly risky.
Yeah.
Very early stages. We're seeing AI be deployed in a lot of places. And by the way, scheduling is a great place for it. Administrative, cybersecurity. There's a whole bunch of places to AP. There's a whole bunch of places to deploy it within healthcare that can literally return hundreds of millions of dollars across the health systems, if not billions. But and
don't risk anyone's life.
Right. And that's the thing. It can't be wrong, right? It's a doctor makes a mistake and, we say, doctors aren't perfect, but if a machine makes a mistake, we haven't gone down that territory yet. You're just not able to go down that territory yet. So it has to be right a majority of the time. And now granted, Watson was never going to, do the surgery. It was never going to, make the final diagnosis. It was always going to be in partnership with a physician. So there's a lot of room for this if it gets implemented correctly.
They say the other piece of this though is it's one thing to partner on the data, like them saying to you, we'll clean up your data. It's the other thing to actually own and understand the data, which is, I think, what, Flatiron did, was to say, we are going to be an EMR for cancer. And then they understand the data that's coming in, which results in less having to interpret and clean up the data to find the insights. So I think, Watson was kind of like, we're here. Tell us what we can do.
Yeah, that's the age-old mistake in healthcare, right? To show up and say, we've got a solution. Let us help you. Let us. Yeah, what's your problem? We'll let you help. We'll let you watch while we solve all of healthcare's problems. And they sort of almost did come at it that way. It was almost that kind of bravado. Last week, I keyed you in on something that's unfolding here at This Week in Health IT. We started off with our influencer podcast a little over 3 years ago, but since then, we've been able to introduce Newsday and solution showcases. And last year, we expanded even further with our daily COVID-19 series. And now we have a daily show, Today in Health IT. And I'm happy to say that we're not done growing yet. We have something really exciting happening here at This Week in Health IT. Our goal, as you know, is to help inform, educate, and train health leaders. And we understand lots of people take information in different ways. That's why we're introducing written content to our site for the first time. You'll be able to find news write-ups covering each of our shows in detail, as well as feature stories. And I'm really excited about the feature stories. We've hired two great feature story writers, and they're going to take topics that are highly relevant to you and relevant to our industry, and they're going to turn them into feature stories on our website. I'm so thankful for all of our listeners and the conversations that we've had, our sponsors, and the dialogue that we've had. And the back and forth has really convinced me that this is the best next step. I want to thank all of you for listening and joining with us on our journey of raising up the next generation of health leaders by amplifying great thinking to propel healthcare forward. Truveta is in the market. I talked with Ed Marks about this a little bit a couple of weeks ago. Truveta's an interesting play. So this is essentially a massive data store, about, 10 or so health systems coming together, and they're not small health systems either. I mean, it's Providence, it's Trinity, it's some very large health systems coming together in big data stores. And they're essentially going to anonymize the data and monetize it. Anonymize and monetize.
You should be in marketing.
Wow, that's hard to say, but that's what they're going to do. And obviously, the whole thing's couched under for the good of humanity and for the good of mankind. But the reality is that's in this same vein of we're going to take all this data. But let me ask you this with regard to this.
Yeah.
What do we have to do to clean up the data? You had to clean up some of the data. What do we have to do to clean it up to be ready for AI? I mean, is there a path for this?
No, I don't think there is. I don't think there is, honestly. I mean, I actually I'm happy to, I think it's still up on the Wellpepper website, but I wrote a number of blog posts on this, one in particular called Garbage In, Garbage Out. And it's not so much that, I don't want to insult people and say that everything in the EMR is garbage, but we know that it's not consistent. We know that it hasn't been consistent over time. And a lot of the information is in the notes. And, I just anecdotally read a pretty interesting Twitter thread of a doctor who was talking about the terrible notes that the previous physician had put in, and she couldn't follow them, and they were too wordy and they weren't getting to the point. And then she read it, she realized it was her. So I think that's a lot of the challenge. I'm actually a big fan of small data instead of big data, because the smaller the data, the easier it is to actually interpret what's going on. And that's, at Wellpepper, we had patient care plans that we had defined. And so when the data came back from those care plans, we knew what the patient was doing and we knew what we had asked them to do. And it made it much easier to actually, apply machine learning to see, for example, is somebody at risk of dropping off their care plan? So I would like to see less here's all of our data, and more focused, and perhaps even more thought about how much data is healthcare generating every single day? Are there ways that we can just make the ingest of that better, rather than going back and trying to, just look at absolutely everything that's been created? And then also what's the hypothesis? What are you trying to find out? Because there's different ways to do it, right? You can do a cluster analysis and say, here's a bunch of data, machine learning, please tell me things that are the same. And then you can go and say, okay, well, what's the same about these? It's really interesting, but it's very academic and going to take you a long time.
Yeah, I was always trying to quantify the value of the data, and the data with the highest value to AI machine learning, and really a lot of our analytics was stuff that didn't pass through human hands.
Right.
right? So all the telemetry data was beautiful. It just passed right in, and it was very clean. Exactly. So then the question became, all right, if that's our best data to work with, how do we get more of the data like that? That doesn't pass through human hands anymore. And I think that's the next step. I mean, clearly there's going to be stuff we have to get through notes and that kind of stuff, but and we could think through how we're actually collecting that and how we're getting it in. But at the end of the day, more streaming data directly from the body is going to be a lot better for us.
As a patient engagement advocate, I think the other thing is that what happened in the hospital is only a very tiny thing. Like the rest of my life is lived outside the hospital. And so that kind of goes back to, again, like looking at specific problems that happen within the hospital that you can fix. You started off on the administrative side. I think that's great. I know there's been work done with sepsis. So, like 90% of the patient experience and data is actually outside of the hospital. And so think about what are you trying to solve?
Well, here's what I've always wanted. I wanted a 4-point data set to start to apply all my data practices to, and it was essentially the EHR data. Okay, great. We have that data set. I then want your browser history, and I want to be able to mine that. I want to be able to your shopping history and your grocery store. I mean, I want to take those 4 data sets, and I think we can make a pretty comprehensive whole person profile and almost predict where you're going to struggle with regard to health. And maybe, I mean, clearly education's important there, but that's like 2 or 3 data points and away you go.
Yep.
So, wow. Anyway, let's see, where can we go? So that's IBM Watson Health. You talked about Microsoft. What's going on at Microsoft?
Well, so this is a little bit not entirely related to health IT, but it is, because IT cares about, employee productivity, and, like we have all in hospitals, we have all these people who are not, administrative, running the hospital, all these employees. So Microsoft announced a new portal. A portal sounds like such an old word. So can you have a new portal? A new way of having employee experiences. It's called Viva. And, I said my personal connection to this, I did actually used to work at Microsoft and on SharePoint, but it has some components of SharePoint. But I don't know if, obviously Microsoft must have been working on this for a while, but it does seem a little bit COVID related in that it came out to, as we're all working at home. And it's this, it's like supposed to be your digital front door, I guess, to your employer and your productivity. So what are you working on? What's going on in your organization? But what I thought was interesting is that if you look at some of the articles, there's a tiny snippet of wellness, employee wellness as part of this. So it's not just, hey, what's the news going on in my company, or what documents was I working on, or who do I need to collaborate? There's a little bit of check-in of how are you feeling today? And I thought it was interesting because, there's a whole industry around employee wellness, and, companies like Limeade, and, that Microsoft's trying to put a toe in the water here. But also, there was some backlash around, it's tracking your productivity and telling your employer potentially when you're working and when you're not working. So that's a question of that's definitely something that does not help with wellness. But I was also thinking about it from a couple standpoints. The portal or the internal intranet as a wellness activity, which is kind of interesting. I was also thinking about the doctors and nurses and healthcare workers who are really, talking about burnout, and then they're given these wellness modules to do. And they're like, this is not, that's not the problem. So solve the core problem, which is, not enough resources and all of these things. So that's another component of it. And then just how fine the line is when technology starts to try and tell you how you're feeling. And I go back to this, I did a talk at HIMSS one year on how to deliver empathy through technology. And I fully believe that it works, that you can. And one of the examples I gave was when I first got my first iPhone. I was looking at it and it said, "You have a busy day tomorrow. Your first meeting is at 8." And I was like, yeah, I do have a busy day. Thank you for noticing, iPhone. And it felt, like, okay, my phone's looking out for me. Let's compare this to something that Microsoft did, which is, Outlook gives you your productivity stats, and they do it in arrears. So they have been, monitoring you. So in January, they sent me a thing that said, "You have been working outside of business hours every day for the last month, except for 2. One of those days was a Sunday and the other day was Christmas." Well, I was selling my company. You don't think I know that I was working a lot? Like,
now you want to get in an argument with it and say, "Do you not understand what I'm going through?"
So those are some of the things that this brought to mind. And I thought about, like, rather than telling you what happened, maybe come up with something that can help you. Like, hey, I automatically put a block on your calendar because you've got these 2 meetings and I know you're going to need a space between them to think, because one of them's with your vice president. So those are all it's a little bit squishy of thoughts, but those are all the things that came up. And I was particularly like, do you want your portal every day to ask, like, are you happy today? Like, I don't know.
I do want to talk about this specifically. This is interesting. And by the way, you sent me a Verge article, and the woman sitting behind the desk in the top picture, that literally could be like your picture from 20 years ago, sitting at a desk at Microsoft.
There's a funny thing that Microsoft has, that you can sign up as an employee to have your name used in documentation and advertising.
Really?
And I did it because, as a former technical writer and as a sometimes marketer, I know how hard it is to get fake names, and if you do poor fake names, it's troublesome. So I signed up, and I have advertised many things. Windows Phone in particular was, when Ballmer was on the Today Show, the demo had my name on it.
Oh, wow. So that was your 10 seconds of fame right there.
This is my claim to fame. And actually, you'll love this too. One time a friend of mine was in a store, picked up a Windows Phone, like the sample phone, and it started doing its little demo thing, and it's like, "You have a new message from Ann Weiler." And my friend was like,
how did she do that? That's funny. But you bring up an interesting point on technology, and we have not been good at this over the years. And it wasn't until, I would say, about 7-8 years ago that I started looking at the psychology of rolling out technology and the impact it has on people and how they receive it and how they interact with it. And I think this is a growing area. I've talked to several people now of development teams that are bringing those kinds of psychological and sociological just research and things to bear on how are people going to receive this technology? How are they going to utilize this technology? How do they want it to talk to them? What verbiage do they want to hear and not hear from their technology? When they say one thing, it might sound like Big Brother, and when they say it another way, it might sound like grandmother. It's
that's
like,
right.
"Oh, thank you for putting your arm around me." And so it's just one of those things. All right, let's talk about this. This is essentially an evolution of the intranet.
Yes.
Great. SharePoint was always a lackluster intranet and a security nightmare for me, but that's a whole other thing. Anyway, so they split this up. They have 4 modules. They have connections, insights, topics, and learning. And it's interesting. So connections, think of connections like social media for your organization. So it's ways to connect, not only, I think, within your organization, probably externally. So they're probably hoping that it becomes like a Slack kind of thing. Topics is like Wikipedia. You can essentially look up things like, what is that project within our company? And for larger organizations like our health system, that would have been helpful for
Yeah.
onboarding and bringing people up to speed. Insights is what you talked about. It's looking at it, some retrospective and whatnot. It's asking you questions, and they give you the smiley faces. How do you feel today? And they can track that and put all that stuff in. It gives you some things. They got in trouble with the productivity score basically because managers were able to drill down into it and say, Ann's only working 3 hours a week. I mean, literally, that's the level of detail they allowed people to drill into. So that's why they got a fair amount of pushback on that. I think they've updated that since that time. And actually, I haven't gotten a chance to look at this. I'm just reading the article of what they have and then learning. I'm not sure what learning itself is, but that could be an LMS, could be a learning management system for.
Yep.
So if you think about it from a portal standpoint, they've got and Microsoft's good at this. They covered the categories. Now the question is, how well did they cover the categories?
Right.
Conceptually, it's an interesting concept, and Teams is everywhere in healthcare.
Interesting.
I go Zoom call, and if I'm talking to a health system, I have to go over and jump onto Teams.
Oh, is there a security related reason for that?
No, it's
an enterprise agreement. Really,
that's exactly what it is. It's the easiest agreement to sign and to extend. And given what was going on during COVID, you didn't really want to renegotiate another contract. You just fired up Teams, and a lot of them were they were already heading in the Office 365 direction anyway.
Yeah.
So it wasn't hard to stand this up, and it was the most integrated with everything that they were doing. So this will be interesting. I suspect we will see a lot of these sites sort of take off, and we will start. I'll have to start hitting up some of the health systems to determine what their plans are with this, because it should be.
Yeah, that was my thought too.
Should be interesting. Can we talk about the home a little bit?
Yes.
So the home has always fascinated me. I think we're seeing CMS start to loosen their pocketbooks and start to reimburse for things that are going on in the home. CVS Health launched Senior Medical Alert System, and it's a much more sophisticated than the, I've fallen and I can't get up. It has a which I forget what was the name of that company.
Lifeline.
Lifeline, yes. It's a more sophisticated version of Lifeline. It has a suite of sensors. It can monitor falls, motion, room temperature, also providing 24/7 personal emergency response platform for use. So, CVS is partnering with them. They see this as a deployment model. Clearly, if they're partnering, they're going to have somewhere where they can monitor this. They're going to have a command center of some kind where they can monitor this and deploy resources against it. And it was interesting because I found this because Aaron Martin posted something on LinkedIn, and he said, we've seen a lot of these over the years. Will this one succeed?
Yes.
And I sort of looked at it and I'm like, it really could. And it could for a couple of reasons. It can because never forget that CVS is one of the largest payers in the country. Mm-hmm. And so they get paid to keep people healthy.
Right.
And this is a healthy play or a health play. So that's good. It's keeping people in the home instead of getting care at more expensive locations. So financially, it makes sense. Mm-hmm. The other thing is CVS's reach is national. Mm-hmm. And, the sensors and the technology, quite frankly, at this point are getting to be fairly inexpensive, easy to deploy.
Yeah.
And so when he said, we've seen a lot of these, will it succeed? My first blush at that was, yeah, it really could.
Yeah, I think, there's the technology was never a bad idea. I think you need a whole bunch of factors in play for people to accept it. And I think most people, I think I saw a study on this for the longevity, it's like 80% of people, or some research I did, I think 80% of people or more want to age in place at home. The COVID certainly, with all of the challenges with nursing homes to begin with, being the site of all the infections and death, it really reinforced to people, yes, I want to stay home. And so that may kind of remove some of the stigma of the home monitoring and the late night, the late night TV, help, I've fallen and I can't get up. Sensors being smaller, I think help as well, like wearing, and families being remote also helps. So it's, you know that you need some of these things to stay in touch. And, I interviewed a whole bunch of seniors as part of some of the research that I was doing. And one of the seniors I interviewed she lost her husband about 6 months ago. And she was wearing, the necklace thing. And she's like, no, of course, I'm alone. Somebody needs to know if I've fallen. So I thought it was, people really start to understand the implications more. And then I think the issue is, do you trust who's doing the monitoring? But I certainly like the idea of sensors better than trying to build these smarts into all these devices. Like the one that I find completely ridiculous is the refrigerator. No, because seniors are not going to replace their refrigerator with some new smart refrigerator. So by the time everybody has a smart refrigerator, it's going to be for me potentially. But even, I just got rid of a 40-year-old refrigerator. I'm not kidding. So I think there's this, it could be there's a trust issue. There's an acceptance of the potential invasion of privacy, because it is. And then there's a timing issue. And certainly I think COVID has highlighted why people may not want to be in a senior living facility. And then sort of like, I want to say convenience, but there are more services now that you can get at home. So it's not just the monitoring. It's, if some people like to go into assisted living because they don't feel like cooking anymore and they don't feel like caring for their home. Like there are ways that there are so many more, gig economy or other types of services that it is definitely more possible. I think that my challenge is that devices are not, like, yes, that can tell you if something happened, but I'm really interested in the preventative side and the community side. And, it's like loneliness that's the problem, and are you being active? And, the monitoring can tell you what happened, but it can't actually change the behavior that we need to change for people to live longer and more independently.
It's interesting to talk about all this stuff. Let me give you the perspective from a healthcare CIO perspective. So we did try to do some of this stuff in our home health program. We actually went into people's homes. We had a small team, went into people's homes. We set these things up. Usually it was for specific cases, for like monitoring for 30, 60 days, something to that effect.
Yep. And
then we would go in and take the equipment and move it somewhere else. We did have a call line. And and they would tell me stories of, there's this one guy that calls every day, and he calls every day, mostly because he wanted to talk to somebody.
Yeah.
And, but that was, again, that ended up being part of the service that we ended up providing. Let me tell you some of the things that were hard about this. One is sending that team into people's homes. That's no small deal. That there's a special, first of all, there's a legal framework for doing that. There's a training aspect for doing that. So that was not easy in and of itself. The second thing is we based it on an iPad that was completely wiped. The only thing you do with it was monitor a handful of your devices and make a call into this line. And they broke them. I have no idea how. They'd pick them up, they'd take them, they'd move them, they'd become disconnected. And so we had to continually think through, okay, how do we make this thing like completely proof of no one can break it?
Yep.
And so we were constantly engineering around it and that kind of stuff. And then second of all, and then the final thing I would say is that call center is really important. It is a cost, and you need money to sort of fund it on the other side. So we were never able to scale this up because it never made money.
Yeah.
But if we were a payer, that would be a different equation. That's why I think this might work on this side, or for health systems that have a significant managed care population or an at-risk population.
Yeah, your point about the, who's the team going into the home is definitely a key one. And then also, how durable are these sensors? Are they going to fall off and give a false alarm? There's so much complexity. And I mean, CVS probably has the pockets and the patience to do this, but it's really complicated.
Yeah. Well, that's all for this week. Wow, we've talked a long time. I appreciate appreciate you coming around.
But before we go, I saw that you just joined Clubhouse.
I did just join Clubhouse. I have no idea what it is.
Well, we could be having this conversation on Clubhouse. We could set up a room on Clubhouse This Week in Health IT, and people can come and listen to us live and ask questions.
Okay, can we actually?
We wouldn't see our beautiful faces because it's audio only, but there are lots of healthcare folks having conversations there. Doctors, nurses, talking about patient care. There's venture folks talking about digital health. All of your healthcare friends are there. You'll see. So it's like, someone described it as like a live call-in show. It's a little bit like that.
Wow. Can we actually do our recording? And
actually so the one difference is they ask that you not record it. It should be a live event. So it would be a lot. But what we can do is, we can have a room and have people come, and we can actually, people can ask questions and things. So
wow. Well, I'm looking forward to delving into it. Somebody told me this morning that I needed to be on Clubhouse, and I thought I will do it. I will do it.
I will say, as a heads up though, is they have been criticized for their privacy. And I think the other really interesting thing is that there's so many people in there having conversations, and their employers can't hear the conversations unless they're on Clubhouse.
Oh man.
So it's a private network right now. So that's kind of interesting.
Well, it's really private. I went to sign up, and it said we're not ready for you unless somebody lets you in. And one of my friends inside, I guess, vouched for me.
They didn't ask me to let you in. I would have let you in.
Yeah, I was anyway. I'm excited. We'll have to as I venture around there, I'll see if I can find you and what we can do in there.
Lots of folks are there. I know Christina Farr was looking at setting up a digital health conversation too. So
cool. Looking forward to it. And thanks for your time. Always a great conversation.
Good to see you.
All right, that's all for this week. If you know of someone that might benefit from our channel, please forward them a note. They can subscribe on our website, thisweekhealth.com, or wherever you listen to podcasts. Apple, Google, Overcast, Spotify, Stitcher, probably some other places that I'm not even familiar with. We want to thank our channel sponsors who are investing in our vision to develop the next generation of health IT leaders: VMware, Hillrom, Starbridge Advisors, Aruba Networks, and McAfee. Thanks for listening. That's all for now.